to move into the next step, which would be to palpate the abdomen. And for this, I'd like to relax the abdominal wall. I'm going to ask my patient to bend the knees. Dr. Afghani, please bend the knees. And that take the tension out of the abdominal muscle and make the abdomen relax for the examination. I'm going to strategize now, assessing the abdomen quickly through light and deep palpation of the generally exposed part of the abdomen. Then I'm going to move to assess the liver and assess the spleen and assess the kidneys. And then lastly, when I'm done with these evaluations, I'm going to go back and evaluate the size of the abdominal aorta artery. So first, you use the bulb of 3 fingers, landing light on the skin, and you push the skin down and roll the skin against the muscle. That's what you're doing in light palpation. And I'm feeling for textures. So I'm trying to nullify the presence of any kind of subcutaneous masses. And as I'm doing this, I'm looking at his face for any evidence of tenderness or pain. And that would guide me to investigate the area more. You be thorough enough to land on the quadrant of the abdomen as many times as it takes to make a proper evaluation. And all through the evaluation, you're looking at the person's face for the expression of discomfort. And as you progress through the light palpation, which you see now, you can go clockwise, counterclockwise. I mean, the way you're going to strategize how to examine will be guided by choice and guided also by the initial complaint of pain, if there's pain present. And you know the area that's painful will be examined last. So I'm done with the light palpation. My report of finding here include absence of any subcutaneous masses that I picked during that phase of the examination. There is no evidence of tenderness observed in the person's face during the process. And as I felt through the abdominal wall, there is no evidence of muscle guarding. And muscle guarding is a reflexive act that takes place when you have damage inside the abdomen. There's peritoneal inflammation or irritation, the abdominal wall muscle will guard without the person putting his mind into it. The next step is to look for the structure below the muscle. And for this, you'll be using the person breathing to guide your procedure. You're going to land on the lower right quadrant, ask the patient to inhale. As the person exhale, follow the tone in the abdomen down and do the same thing. Round, plus sign, X. What you're trying to feel is textures below the muscle. Then surface and land again and repeat. Breathe in and breathe out. And when you ask the person to do that, the person has the expectation that you're going to push in when the person is breathing out. So you don't have to repeat the question. Otherwise, if you lose the synchronization with the person, act. So I'll keep doing the deep palpation for the general abdomen, using the same thing here, expecting that I'm going to land to feel when the person breathes out. And all through, I'm looking at the patient face for any expression of discomfort or pain. Be thorough enough to cover the abdomen, and you remember from the anatomy that the part below the abdominal muscle in the segment is all intestine. Nothing should feel hard in this part. If you land something hard, that is abnormal finding. It could be a reflection of organ enlargement, it could be a reflection of cyst forming in that site, it could be an expression of a tumor growing in that site. So remember that that part here have the same bouncy rubbery feel. There's no hard mass when you land in. And likewise, you're assessing any kind of tenderness that will prompt you to go back and examine the part thoroughly. Now I'm going to target the liver, and if I pick the liver during the general palpation, it will be dropped below where it's supposed to be in a normal anatomy. Normal anatomy, the liver is tucked behind the rib cage, and you have to maneuver to feel the edge of it. So the liver should be in the normal size here. It could extend all the way down here if it is in full-fledged hepatomegaly. So to target the liver, I'd like to start from the point where I will be able to meet it if it's enlarged. And that starts me in the lower right quadrant. I'm going to use one of two methods to feel the liver. I might use the knife edge of my index backed up by my middle and ring finger and be perpendicular to that line. I might run 3 fingers parallel to that line with the middle finger line up where the mid-clavicular line. The mid-clavicular line is a guiding line here to palpate the liver. Mid-clavicular line is the line that bisects the clavicle in half, and that line usually drops just medial to the areola of the breast. So that line is the mid-clavicular. Usually when you have a measurement of the liver, when we progress in the percussion, that will be conducted along that line, and everybody doing the follow-up will have the same measurement in the same line. So I'm tracking that line from the lower quadrant up. I'm going to ask him to breathe in, and I'm going to synchronize myself with him breathing out, and then keep progressing up to get to the edge of the liver. And when you get close to the edge, use the skin to round your fingers below ribs and try to feel that edge of the liver and the part that will meet your fingertips. If you feel the edge of the liver at that phase, what you're trying to assess if that edge is tender. So the two indicators here that prompt you to investigate the liver further would be enlargement, and tenderness or tenderness. So when I try to reach in to tease the edge, I'm trying to provoke that tenderness and also assess the texture of that edge. A more thorough evaluation of the edge involved me using a different technique that's called the hooking technique of feeling the edge of the liver. Here I'm going to step to the head of the table. My hands will run just below the edge of the rib cage, and I'm going to line up my fingertips to make a line. You see I'm giving myself some skin here to roll my fingers up. I'm going to ask my patient to breathe in, looking at his face. I'm going to drop my finger bulbs in, roll up, and tease the edge of the liver, and let go. Again, remember that you don't curl your fingers in to cut the skin with your fingertips, using the bulbs, the soft part of your fingers, which are the most sensitive part to feel. So again, I demonstrate one more time. You line up your finger on the same line. You ask the patient to breathe in. You look at the face, drop down, and tease the edge. And what you're trying to look for is expression of pain in the person's face. Very important you perform this in the OSCE is to look at the face, because you cannot assess anything beside, the tenderness. Of course, you'll be able occasionally to feel the texture of the edge, but the important part here is to exclude the possibility of the tenderness that could be associated with hepatitis. The next step is to evaluate the spleen, and the spleen is in the upper left quadrant. A normal spleen is not approachable by palpation, and if it comes in to be palpable in the abdomen, at least it is 3 times its original size. So I'm examining the spleen here with a mindset, if it's normal, I'm not going to feel it. And if it drops in the abdomen, it will give you that hard feel of a mass in the abdomen. You're going to come up from the lower part of the upper left quadrant and progress below the umbilicus and show up around the umbilicus here. So strategizing here, I'm going to start right lower quadrant and then use the same method that we talked about before here, using the tips of my fingers, trying to meet that spleen if it is in the abdomen. I'm going to just lightly go in and then go deeper, and I'm trying to go in deep enough to pick up below the edge if the edge exists in the abdomen. If you come up to the edge of rib cage here and you don't feel it, you're trying to bring the spleen close to you. And what you're doing here is cuff the rib cage with one hand, rotate the rib cage towards you, and try to feel the spleen coming in your fingertips. If it is not there, it's not enlarged. Before you conclude it's not enlarged, ask the person to inhale and hold. And if the spleen is enlarged marginally and it is already close to the spot, the diaphragm will push it down and going to show up in your fingertips. Relax, ease. And now I'm going to ask the person or the patient to turn on the right side, left side up. And as he does that, I'd like you to ask him to rotate and drop the shoulder forward, the top shoulder forward. And what I'm trying to do here is disadvantage the spleen, because the spleen, normal spleen is here, it is enlarged here. If I'm doing this and I'm asking to rotate and ask him to breathe, that spleen will drop down in my fingertips. I'll be able to feel it. So that is the bimanual assessment. If you don't feel it at that phase, the spleen is not enlarged.